Greetings. I'm coming to you today from the GLEN, which is this beautiful recreation area in suburban Chicago that was the site of the former Glenview Naval Air Station. And now it's been converted into this beautiful place where you can enjoy yourself. There's recreation here, there are playing fields, there's a school, a wonderful path that you can bike, and it indeed is a wonderful thing now to have a military installation turned into a peaceful place for all of us to enjoy and to play. Today I'm going to talk about another tragedy. It's the case of a fatal pulmonary embolism after a tibial plateau fracture. And I would like to say, to begin with, that this is a real story. Now, I have made extensive changes to the details of this story as far as hiding the identity of the person involved, but the accident and its aftermath are real. We're going to talk about Anna, who is a 47-year-old assistant patrol director of a ski patrol in a western state. She's married with 2 children, and she is one of those people that is very, very skilled, and is part of the avalanche team that goes out first thing in the morning and takes care of the mountain. On your left, ladies. Thank you. On your left. Now I'm going to be jumping back and forth here. Here you see the school that's a part of this wonderful complex. And in the distance, some beautiful buildings. So what happens first thing in the morning is this lady goes out along with the other skilled patrollers, and they have dynamite with them, and they go to the top of the mountain, especially after a heavy snowstorm which occurred the night before. And they throw dynamite to have controlled avalanche the settings. They set the avalanches in controlled areas to make sure that the runs below are safe for the public. And this was in the springtime. And as a result of that, in the springtime you have something which we call on the patrol snow cookies. And that's where there is a frozen ball of ice and snow, sometimes the size of a grapefruit or even larger. And when you have a situation where the snow has fallen the night before, what happens is that it covers up these snow cookies. So this brave patroller is skiing at the top of the mountain. She hits a snow cookie, it knocks her ski off. She instinctively puts her leg out to break her fall. And as she does, when the leg hits the ground, the femur, which is the hip bone, on your right, thank you, on your left, thank you, the femur smashes into the tibial plateau, which is the top of the knee joint, and crushes the plateau. And here I'd like to stop for a minute and just show you what has been preserved from this which you can see up there, the U.S. Naval Air Station, Glenview, Illinois. And they've kept the control tower in that main building. And the rest of these were all runways and so forth. So back to the story. So she falls, and as she falls on that leg, the leg scrapes in the rocks and produces road rash, which is open areas of abrasions on the leg. But through her skills, she is able to successfully self-arrest. And in so doing, she saves a 3,000-foot fall down the mountain. The patrol picks her up, takes her by ambulance to the local hospital where her leg is evaluated. She has a CT scan which confirms a tibial plateau fracture, and then a closed reduction, which is just reshaping the bones to sort of be in the right position, but definitive surgery can't be done because of the road rash and the fear of infection. So she's put in a straight leg knee brace, which allows her to flex her foot up and down and move her hip, but no movement of the knee, of course, and it's in the straight leg position. Now she is instructed to move around as much as she can with the walker, using her other leg and flexing the foot and also moving the hip joint in order to prevent blood clots. So she does this for about a week, and following this, she goes ahead and sees the doctor again and reports to the doctor that she's still having some considerable pain and that she really can't lift her foot up, because when she does lift her foot or bend at the ankle joint, it hurts her in the calf. Nevertheless, she's given more pain medicine and sent home for another 10 days. So now we're about 16 or 17 days out. She's seen again and the wound is healed. She's brought into the hospital in preparation for her surgery, and then she's taken to the operating room. And when she has her operation, it's very successful. They start by putting a tourniquet on her leg, and the tourniquet is very commonly done because that controls some of the blood loss. Sometimes in these injuries are very bloody, and the tourniquet's a very effective way to temporarily block the circulation so that the surgeon can get the work done in an efficient manner. And that happens, and she has about a 2-hour anesthetic with about an hour and 20-minute tourniquet time. But when they release the tourniquet, she arrests and dies. They try to resuscitate her, and she's in the operating room under ideal circumstances with the anesthesiologist there and, of course, the team, but they were unsuccessful. An autopsy was done and shows multiple large pulmonary emboli. And these pulmonary emboli, when taken out of the lungs and put end to end, create a perfect cast of the femoral vein in the thigh of that leg. In addition to that, she has multiple calf veins involved with clots that are still in the calf veins. Again, the team is astonished as how this could happen. It's on your left. And I'm always amazed at problems with trying to let people know on the bike path. Anyway, everybody is really upset, as you might understand. And what happens in these cases, of course, is that in every hospital there's a morbidity and mortality conference where any cases where there are complications and or death are presented. So this case is presented at the M&M conference run by the chief of surgery. And as often is the case, at that conference is a vascular medicine specialist. On your left, thank you very much. Hi. And that vascular medicine specialist is there to talk about cases that involve, for example, circulation issues and blood clots. And so the the doctor's invited up to the podium and says, well, I'd like to share a few slides and tell you what I think happened to this case. So he said, first of all, when the crush injury occurs, the crushing of the bone in the tibial plateau opens up the bone marrow. And that bone marrow contains fatty substances which then can get absorbed in the bloodstream and cause clots. So that's a risk factor. And then the tissue being disrupted and the bone being fractured, tissue juice, we call it, products that normally don't get in the circulation gain entrance into the circulation, and again they can trigger coagulation and clotting. In addition to that, there's swelling about this knee joint, and the swelling produces further obstruction of the vessels around the knee, which then again obstructing the venous vessels lead to blood clots. And of course, not only are the tissues, thank you, good morning, not only are the tissues crushed, but also the lining of the veins is damaged. Thank you very much.
You're welcome.
And as a result of that, those open areas in the vein now with the cracks, that can trigger blood clots. But that's just what goes on at the site of the fracture. The fact that the patient is non-weight bearing is a phenomenon which has been studied, and it's amazing. In a very simple fashion, people have been evaluated who are non-weight bearing and compared to partial and full weight bearing using the duplex ultrasound scanning. And Jonathan Craik has produced a beautiful paper indicating that patients who are non-weight bearing have no increase in their blood flow over sitting down. So there's what we call venous stasis or puddling. It's like stagnation in a pond. And that's not very good, because as a result of that, the veins get bigger and bigger. Because you know, the arteries are continuing to pump blood into the leg. And if there's an impairment in the venous circulation of the blood getting out of the leg, then as a result of that, the veins get bigger and bigger and bigger. And finally, they get so big that the walls over distend and they crack. You can hear children playing in the background there probably in this beautiful Glenview environment. So we have another phenomenon that's going on, and that is that the arteries are pumping blood into the leg. They keep pumping blood into the leg. So that further increases the congestion in the leg, and there are waste products from the muscles, because the muscles are continuing to function and live, and those waste products are also excreted into the circulation of those stagnated veins, and all of that triggers blood coagulation. So you have in this is like a little chemistry experiment or lab experiment. I call it the witch's brew, where you have stagnation of the blood, activation of coagulation, and damage to the vessels. And if we go back in history again, in 1856, Rudolf Virchow, a famous pathologist who was in Germany, in Berlin, came up with the 3 reasons or postulates why people develop venous blood clots. And they are congestion, vascular damage, and hypercoagulability, all of which are occurring in this calf after the injury. In addition to that, because the leg is in a straight leg position, what happens is that the head of the gastrocnemius muscle, the big muscle in the calf, can block the popliteal vein, which is the major vein behind the knee, and slow blood flow out of the leg, because it constricts that vein and the blood has to go around it to get out of the leg through the surface veins. And you probably all are familiar with this phenomenon, because guards standing at attention are urged not to keep their knees locked straight, because that could lead to them fainting because their circulation is impaired. So there's a lot of factors going on here now In the average tibial plateau fracture, where once the injury occurs, if there's no break in the skin, usually these skilled orthopedic surgeons, and they do a marvelous job, are able to do what's called an open reduction and internal fixation, ORIF. And that's where they open up the leg with an incision, they straighten out the bones, and after they do that, they put a plate and screws usually to fix it, the internal fixation part, and then close the wound. And so all of these factors, the venous stasis and the non-ambulation and the sludging and hypercoagulability, they only last for a very short period of time until the patient has definitive surgery, and then that helps. But in this particular case, this lady had 17 days where she was in this immobile state, and she wasn't given anticoagulants. I guess the doctors were afraid of bleeding, and they didn't really fully appreciate all of these risk factors. And by the way, she had some additional risk factors because she was on birth control pills and over the age of 40, and her BMI was over 30, even though she was very athletic. So that all of these added up to a sort of a perfect storm. And as a result of that, when she went to the operating room, thank you very much, another factor was introduced, and that was the tourniquet. And the tourniquet is very commonly used. It's a very safe procedure, and it helps to limit bleeding at the time of surgery. But it's also a risk factor for blood clots. And as we saw in this case, when the tourniquet was released, a large blood clot from the thigh embolized to the lungs and caused death. Now I'd like to cover a couple of more little things here, and that is that the doctors examined her leg when she came in, and they squeezed her calf and it wasn't tender. So they concluded from that they weren't worried about blood clots. But what they didn't realize is that 80% or more of blood clots do not present with any symptomatology such as that until a major event occurs, like a pulmonary embolus. And John Haidt, who's a famous epidemiologist at the Mayo Clinic, has done some interesting studies, and he has shown that on your left, thank you, these interesting studies have shown that in the United States, he estimated in a given year that a third of all patients that develop fatal pulmonary emboli present as sudden death. So there's no premonitory signs or symptoms. So that's a very, very dangerous situation. So one has to be aware of the setting where this could occur. And the other thing that wasn't really explored here is the patient had a positive Homan sign when the foot was forced upward or flexed at the ankle joint. She had pain in the calf. Now, a lot of people think that that's synonymous with a blood clot, but that's not true. It's a very nonspecific sign, and it can indicate a ruptured muscle, bleeding in the calf, a tumor in the calf. On your left. Thank you very much. Thank you. Good morning. Hi. A lot of wonderful people out here today, able to enjoy this beautiful place. And isn't it a wonderful thing now that a former military installation can provide so much happiness and recreation for people? So, that positive Homan sign, plus all of the other risk factors, the vascular medicine doctor came to the conclusion that if this lady had had a duplex scan preoperatively, her life would have been saved, because they would have picked up those blood clots, delayed the surgery, treated the blood clots, and then made arrangements to appropriately do the surgery under the control of anticoagulation, maybe vena cava filter, and so forth. So the moral of the story is to learn about these risk factors and to make sure you utilize duplex scanning to make sure that there isn't a clot before you operate on the patient. And unfortunately, the guidelines mislead us a little bit, because the guidelines for orthopedic surgical patients do not recommend doing routine duplex scanning before an operation for a total joint. But now, first of all, this isn't a total joint. And secondly, there's nothing routine about this. This is doing a duplex scan for cause. So remember that, to use that as a duplex scan for cause. So that's about it for today. I would like to thank you all for watching this channel, and I hope you all stay safe and have a wonderful day.